Hello. Our group will be presenting a case-based analysis of Paula. This project is part of OTP 515, where we are focusing on developing professional reasoning skills and applying clinical knowledge to complex client cases. Paula is a 76-year-old Caucasian female with a primary diagnosis of Parkinson's disease. In addition to that, she also has secondary diagnosis of cataracts and hypertension. Paula currently lives in a skilled nursing facility where she receives long-term care. Prior to this transition, she lived at home with her husband Dave and was supported through home care services. Professionally, she had a long career as a history professor before retirement, which tells us that she has a rich intellectual background and values lifelong learning. Paula's Parkinson's disease presents with several hallmark symptoms such as bradykinesia, or slowness of movement, rigidity, which limits her flexibility, postural instability, which puts her at a higher risk for falls, and intention tremors, which also occurs when she is trying to perform purposeful movements. One particular notable feature in her presentation is pronounced axial rigidity with left lateral trunk flexion, a condition commonly referred to as Pisa syndrome. This significantly impacts her posture and balance, which is in turn influences her mobility and ability to engage in daily activities. In addition to Parkinson's, Paula's cataracts contributes to reduced visual acuity and decreased contrast sensitivity. This is not only affects her ability to recognize objects and navigate her environment, but also increases the potential for accidents and a difficulty with meaningful occupations, such as reading or engaging in leisure activities. Finally, her hypertension introduces additional cardiovascular risk, especially during exertion or physical therapy sessions, and requires careful monitoring. When we look at these conditions together, it becomes clear that they interact in ways that directly affect Paul's functional independence, her overall safety, and her quality of life. Understanding the combination of these factors is essential for us as clinicians as we begin to consider her occupational therapy needs and the most appropriate interventions.
So for our next slide, we have scientific reasoning, which are signs and symptoms and risk factors. So Paula presents with significant motor and postural impairments. She has very poor trunk control with a rigid log-like posture and lateral flexion to the left, which limits her dissociation and balance. Her neck range of motion is reduced to about one-third of normal, and her head remains tilted to the left. In her upper extremities, her strength is fairly strong, about 4 out of 5, but she demonstrates gross and fine motor incoordination, as well as bradykinesia, a mild intention tremor, and micrographia, which makes handwriting almost illegible. In the lower extremities, she shows moderate tone and left sided tremor and spasticity, which interfere with sitting balance. Functionally, her mobility is unsafe. She relies on furniture walking, has frequent falls, and often flops during transfers. Her ADLs are impacted. She needs assistance for lower body dressing. She struggles with buttons and is dependent for shoes and stockings. Feeding is independent but slow, with tremors and some drooling during exertion. Although her cognition, sensation, and hearing are intact, she has noticeable psychosocial changes, including irritability, loss of meaningful roles, and frustration with her current environment. Although these signs and symptoms highlight the significant reasoning behind her needs for OT services. So, for diagnostic reasoning, why does the client need OT services? So, Paula requires occupational therapy services because she demonstrates clear performance deficits across daily activities. She struggles with bathing, dressing, and toileting safety due to poor balance and trunk control. Her fine motor incoordination and tremors make feeding and buttoning clothing difficult. She is also at a very high risk for falls, which threatens her independence and safety. And beyond her basic ADLs, Paula has lost participation in meaningful roles and activities such as scholarly work and online engagement. which impacts her sense of identity and quality of life. OT can address these needs through remediation and compensation. This includes improving motor control and posture, providing adaptive equipment and environmental modifications, and helping Paula build safe, consistent routines. Therapy also supports safety training and strategies for role resumption so that she can regain independence and return to activities that matter to her most. And then with the next slides, we have procedural reasoning. So, what specific interventions can meet her goals while addressing these deficits? So, from a procedural reasoning perspective, Paula's conditions directly affect her functional outcomes and participation. Her rigidity, bradykinesia, and lateral trunk flexion lead to poor sitting balance, unsafe transfers, and difficulty with lower body self care. Her tremor and coordination issues make feeding and dressing slow, effortful, and frustrating. In addition, her cataracts increase reliance on contrast and lighting, making her visually dependent for self task completion. And finally, her hypertension means therapy must carefully monitor exertion to ensure safety during mobility and activity. These factors guide our clinical decision making and will focus on procedural control, safety, safe transfer training, adaptive equipment for dressing and feeding, and environmental modifications to improve contrast and lighting. By addressing both the physical and contextual barriers, OT can improve Paula's independence, reduce fall risk, and support her return to meaningful participation.
Narrative reasoning. Independence in daily life and decisions is something that is clearly very important to Paula. She has an identity as an educator and a scholar. She's a retired professor, and she still reviews manuscripts as well as holds a room on campus. She really values the daily connections with her husband, family, and colleagues. She enjoys intellectual engagement and she would prefer to do it with a computer to stay mentally with it. She really wants to maintain ties with her colleagues and former students by using her computer. She wants to increase her independence with bathing and dressing, as well as getting back to some normalcy by eating in the dining room. She wants to increase her confidence by having fewer falls, and she really wants to have reliable internet so that she can make those online connections. And she's very frustrated with the noise with her roommate's TV. So all of these things are what make up Paula's current experience. 3 goals that Paula has stated are: 1, to have her computer with her and have internet access on hand to stay mentally with it and connected. She stated she wants to bathe and dress independently every day, and she has stated that she wants to eat in the dining room.
So, from pulling information from Paula's case study and from using different forms of clinical reasoning, we were able to put together a list of Paula's key problem areas that can impact her ability to participate in OT. So, number 1, she has poor sitting balance. From her Parkinson's, she presents with left lateral trunk flexion, which causes her to slide off the toilet and chair when trying to perform seated tasks. Number 2, she has poor safety awareness during transfers. She's had frequent falls recently, and instead of using her rolling walker, she's been attempting to furniture walk, and she flops onto the chair or bed frequently when performing transfers. Number 3, she's dependent with lower body bathing and dressing. She has difficulty bending and reaching during these tasks. Number 4, she has fine motor difficulties due to her tremor, and this causes for slow feeding and difficulty with buttons during dressing and difficulty with cutting also during feeding. Number 5, due to her cataracts, she has visual impairments, which causes poor accuracy and safety when performing all aspects of self-care. Number 6, from her Parkinson's, she presents with rigidity and bradykinesia with limited neck range of motion, which causes difficulties with postural stability and also when performing mobility. Number 7, currently in her skilled nursing facility, she has some environmental barriers, including her roommate has constant TV noise, and then she also has limited internet connection, which causes decreased participation in OT. Number 8, she is feeling some irritability and role loss currently, which can cause more reluctance towards group activities. Number 9, she feels energy and lack of energy and fatigue with effortful tasks, and also drooling during effortful tasks, which can affect her ability to perform them during OT. And number 10, she dislikes her rolling walker, which leads to poor carryover of safe ambulation. So 2 of the most important areas to address with Paula in OT include number 1, fall and transfer safety, as well as her sitting balance. These both present an immediate safety risk, so working on them will be risk mitigation, will prevent injury from sliding and future falls, and then will provide foundation for all other ADLs and mobility. And number 2, lower body ADL independence, so including bathing, dressing, and toileting setup. And working on these will restore daily autonomy and dignity, will reduce caregiver burden, and it's one of Paula's top priorities. Paula also has some psychosocial challenges which need to be addressed during OT, including number 1, her feeling of loss of her roles and identity from no longer practicing as a professor and reviewer, and this can cause her some frustration and irritability. Number 2, she's feeling environmental distress, currently living in the skilled nursing facility from her roommate's constant TV noise, which is causing her decreased rest and focus. Number 3, from moving into the skilled nursing facility, she's also feeling separation from her home and her husband, which causes for feelings of loneliness and grieving for independence. And then number 4, she's feeling stigma and feeling mismatched from the activities being provided at the skilled nursing facility, which can cause her disengagement from OT programming. And all 4 of these factors can cause a reduced quality of life for Paula. Education for Paula during OT sessions should include strategies for Parkinson's, including external cueing, amplitude movement, and transfer sequencing, including nose over toes and reach back as she's transferring, and also safe walker use using her rolling walker. It should also include energy conservation and pacing techniques, and also planning her therapy time during her on times. It should include adaptive equipment use and setup for dressing, bathing, and feeding, and creating routines for her. Number 4, it should include fall prevention, so education on proper footwear, non-skid surfaces, techniques for performing sit to stand, and educating her on the dangers of furniture walking. Number 5, some vision strategies for her cataracts, so including lighting accommodations, contrast, large print, and using computer accessible programs. And then last, caregiver training for Dave and her family for safe assist during transfers, cueing they should use, and environmental setup.